Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for the second season of conversations aiming to bridge gaps surrounding dysphagia intervention. Swallow the Gap podcast is a production of Gap Education, and we are predicated on a mission to improve dysphagia care. Nothing we say is legal advice, nothing should be taken without scrutiny. While we strive for accuracy, we do not imply perfection. We value diversity in backgrounds and opinions, therefore our guests will not always reflect what we believe. In fact, we may change our minds as we learn more because this is how progress is made. Through critical reasoning with open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Today's episode is sponsored by Aspire Respiratory Products, makers of the EMST 150, EMST 75 Lite, and the IA 150 inspiratory adapter that will work on either device. Visit emst150.com for more details. Welcome, everybody. With me today, I have Dr. Alex Brandimore. She's an associate professor at the University of South Florida in Tampa. Primarily teaches within the master's program. So she does dabble some in the undergraduate program there with some background research in respiratory muscle strength training, and you work there at the ALS clinic. And wow, I'm trying to think of the name of the ALS clinic.
Oh, it's just our multidisciplinary ALS clinic. It's pretty great. It services up to 20 patients in a day and rotates them through all sorts of disciplines, including social work, the ALS Association, dietitians. It works through neurology and speech and PT, all the things so that it's one-stop shopping. It's a long day for the patients, but tends to be really productive.
No, that's excellent. I remember in my last semester, I was in USF as a graduate student, so I graduated from their master's program, and then I came back to work as a clinical instructor when you were there, and that's, of course, how I met Alex. But one of the last things that I did is I shadowed Emily Plowman whenever she was going through the ALS clinic. It was very great experience for me. So I'm glad to hear that you're taking that over. That's excellent.
Yep, it's pretty great. Yeah, I think it is a chance for us. These complex neurological patients always give us an opportunity to have to integrate our understanding of motor speech, dysphagia, cognition, language, and cough. It's no patient is ever clear cut and simple. So it's a great learning experience for students to think on their feet and think critically and also come at it from a really human perspective. ALS is obviously devastating.
Yeah.
And so there's a fine line between like taking it on and taking it home, but also just providing the support that they need. It's a really interesting part of our education for those students.
Yeah. It really exemplifies case-based learning from a number of different areas. So that's fantastic. So I'm glad you're doing that. But you mentioned something about cough. And so we're talking about swallowing, we're talking about cough, we're talking about motor speech disorders. And really all three of those things kind of segue into what we're looking at today. We're looking at respiratory muscle strength training. Would you mind, for a little bit of street cred, providing some of your background with respiratory muscle strength training?
Oh, sure. So in my doctoral training, actually, when I was at the University of Florida, one of my mentors was Paul Davenport, who's a respiratory physiologist. He was instrumental, along with Christine Sapienza, in developing the expiratory muscle strength training device. So again, EMST was developed by a PT in Danny Martin, a respiratory physiologist, and Paul Davenport and Christine Sapienza, who was an SLP, kind of putting their heads together. But he made me take a respiratory physiology class in the veterinary school. And I was learning basically on pigs. It was this intensive course. And it's one of those things where it's like the hardest class you ever take, but it stays with you. It's kind of like neuro for me. And so that's where my training was. I worked on EMST studies in multiple sclerosis during my time at the University of Florida. I worked on it with stroke patients and also with Parkinson's disease a lot. And IMST is something that we integrated into our clinical use at the time during my training and then my early years as a clinician, but a little bit more based on anecdotal data and our own observations. And so that's where my background comes from. I've obviously watched the world of EMST kind of explode as that research has been democratized and reproduced all over the world. And so I think there's such good justification for that device, for the EMST device. And I think there are still question marks in young clinicians' minds in particular about, is there a use for IMST? And if so, where? And how do you use it? And how do you measure it? And how does it compare and contrast? And so I think that's where this conversation is headed. The other thing that you and I talked about before is that this idea that we're going to use respiratory physiology and respiratory therapy as a means to treat swallowing or a means to treat cough it's like peripherally makes sense, but at the same time, I think the mechanism for it is not as well understood.
Yeah.
The reality is that swallowing is an overlaid respiratory behavior. We interrupt swallowing every time we interrupt breathing every time we swallow. So we take for granted this natural sort of neural configuration, this reorganization. And so once that becomes challenging, okay, what do you do? Same thing with cough. Cough is an overlaid respiratory behavior. We have to modify the way that we breathe naturally to cough effectively and cough hard, cough strong, scrub the airways, get aspirate material out of there. So it's really easy when you think of it from that perspective to think, okay, so this person has a neurological condition or some sort of peripheral condition. And for that reason, their breathing has changed. Therefore, their cough and their swallowing is going to be different. There's lots of good research that'll be talked about at the Hard to Swallow conference as well about respiratory swallow coordination retraining in patients. I think that this idea is a growing part of our field and just worth discussing, worth talking about.
Yeah, absolutely. And you mentioned briefly the Hard to Swallow conference, and some people are going to be listening to this after it. Some people might hear it before. But this year, 2024, the theme is looking at more like not novel necessarily, but kind of newer, non-traditional treatment methods. And we've been using EMST for a long time. So specifically asked you to kind of go into IMST because I think it's a little bit more of a black box for speech pathologists. But I think laying the foundations of the overlap of the functions of the systems of the aerodigestive tract for cough, for swallowing, for breathing, that type of thing is an essential part of this. And so like, this is something also that I'm extremely passionate about because I like to look at dysphagia as a big picture thing, not just, are we changing physiology? Of course that matters, but are we changing health outcomes? Are we helping to prevent malnutrition, dehydration, pneumonia, asphyxiation? Are we improving quality of life? Those types of things. And so I think RMST, respiratory muscle strength training, is really a good exemplar of something that kind of checks multiple boxes within that, because we need breathing, breath support to swallow. We need breath support to cough. We need breath support to speak for motor speech disorders. So I don't know. I mean, I could talk about it for 3 hours. So I'm going to throw it back to you and say, what do you think is really the most exciting thing about inspiratory muscle strength training within our profession?
From my perspective, the more tools that we have in the toolbox, the better. I think one of the reasons I decided to do a PhD was because as a clinician, I was kind of like, well, what are our tools? Like, is this all we have? What are the ways that we intervene the most effectively? And I like the idea of using, I mean, obviously I love the data that's come out for EMST in particular, but I think that there's some compelling evidence for IMST as well, for its ability to improve dysphonia, for its ability to improve inspiratory volume and sort of respiratory coordination. I think that there may not be as robust of evidence to talk about dysphagia, but there is definitely for cough and cough coordination. And so there are certain utilities. I think there's also ways to use IMST and expand our patient population. There's some compelling research we'll talk about either today or at the conference, depending on how this goes, about use of IMST kind of prophylactically in our cardiac patients who are about to undergo cardiothoracic surgery, seeing that their actual outcomes are far better if they've done IMST before the surgery as opposed to after. Compelling evidence to talk about its usage in hypertension. Hypertension is rampant, and managing blood pressure is largely a pharmacological, we largely take a pharmacological route. But I think if we start integrating speech pathology more into sort of these cardiac units or into these other aspects of internal medicine or whatever the case may be, we find, we have a role here. And this IMST use and these findings may be one way to really help manage these patients, get them out of the hospital sooner, improve their health outcomes, prevent a problem before it's a problem. I also think that obviously we use inspiratory muscle strength training for weaning patients off ventilators. We definitely have a role with trachs and vents. We do. And there are some situations where that may be the first step is helping get somebody off the ventilator. Well, that's how we intervene. That's how we help. And we then ultimately get them to a place where they can tolerate a speaking valve or something. And then we work on swallowing. So it's kind of, in my mind, it's a way to have a tool that addresses a need and expands our reach as SLPs. Not that the scope of practice isn't huge in our field, but it expands our interests, our necessity. It's great. It's a great way to serve patients with different things than maybe we've traditionally thought about.
Yeah, no, and I think that's great. We have to consider some different ideas, not take them hook, line, and sinker, but put them under the lens of critical evaluation. But we have to consider different ideas in order to expand. I just recorded something with a physician, a neurologist, Dr. Bendix Labite, and he's talking about like other things that are more traditionally within pharmacist or medical doctor territory, but looking at the applications for dysphagia. And I think if we don't think about these things, that we'll really have tunnel vision or we'll miss out potentially on opportunity. And like I said, it's not that all of these are going to work great. Maybe they will, maybe they won't. But until we look into it a little further, how will we know? There's one thing I want to step back a little bit because people who are going to be listening to this are coming from different areas. Some of them are going to be extremely well versed in RMST, EMST, IMST, but some of them are like, well, what is it? Right. So what is it? And so
That's
I'm going to
fair.
put myself out there for a second and make myself potentially look like a fool. And you correct me when needed. But I mean, the idea, you're strengthening the muscles of ventilation, or we kind of colloquially call it respiration, but it's ventilation, air moving into and out of the lungs. And so for inspiration, you have your dome-shaped diaphragm under the lungs. It's contracting and it's pulling the lungs open to suck more air in. And then you have the intercostal muscles, the external ones that pull the rib cage outward for inhalation. And so with inspiratory muscle strength training, you are basically forcing the muscles into overload. You're either doing a pressure threshold device where you have to inhale to a certain pressure level for the air to move or for the valve to open, or a resistance device, which is a little bit more variable to provide some sort of overload to the respiratory muscles, the inspiratory muscle. And so for this, theoretically, if you're thinking of breath swallow coordination, cough, if you have more air in your lungs, hopefully your cough is going to improve. Hopefully your breath support is going to improve. But then you're talking about vent weaning and that sort of thing too. If individuals are getting air and then maybe they can get off the ventilator a little sooner. But I'd love to hear more of the application from you because I think more of the specific.
Well, no, that was a great segue. So remember, inspiration is always active. So when we say inspiration is active, that means that in order for you to breathe volitionally or reflexively, your diaphragm has to contract. So your diaphragm, there is muscle contraction associated with each breath in that you take. Well, let's say that we have COPD, or we have some sort of rigidity in the chest wall, or we have a down regulation, and we're just sort of not taking as much air into the lungs prior to initiating speech or initiating a cough. Because inspiration is active, that muscle can be trained, even in high performance athletes. High performance athletes are people who are about to climb Everest, or they have done this respiratory training for decades. That's kind of actually where it started, was this, okay, if we make the work of breathing harder, then when we take this device off or we take the device away, they'll have better access to their vital capacity. They'll have better access to the air that they take into their lungs. And so there are still devices out there. You could look at like the AeroFit Pro breathing trainer or the Ultra Breathe or things like that, where you're doing that purely as just making the work of breathing more difficult. It's kind of like breathing through a coffee straw as opposed to drinking through like a big gulp straw or something very big. Okay, so the work of breathing increases, and then ultimately you perform better because you've sort of habituated to that, or you've learned how to overcome that resistance kind of thing. Pressure threshold devices are more commonly what we use as far as a rehab tool because there is a load placed on the muscles. It kind of follows one of those principles of neuroplasticity where we have to have enough intensity to drive the muscles to change. So you can actually manipulate the dial. This is very familiar to people with EMST, where you can actually turn it, increase the intensity over time. Same thing with IMST. You can measure their baseline function and then over time, watch that increase. Patients love the biofeedback, by the way, of these devices. That's part of their appeal. But again, when you're talking about why do we do this? Well, so we're training the inspiratory phase of breathing or of cough because it is active. Exhalation, if you'll remember, is passive. It's passive to a certain point. And that so you take a big breath in, you let the lungs collapse until you get to that point of functional residual capacity, where the lung thorax unit is kind of at its happy medium, equilibrium. So then it's only after that functional residual capacity that you actually need those expiratory muscles. So I'm going to blow out, and that's when I activate that transverse abdominis or the internal and external obliques or the rectus abdominis. I don't need those really unless I'm going to cough or do some sort of forced exhalatory effort. So when we start, okay, so that's the utility of EMST. EMST helps with our cough strength. Okay, we also know that EMST strengthens the submental muscles under our chin. They're also called suprahyoid muscles, if that's what you learned in school, to improve hyolaryngeal excursion. That we know that there's this simultaneous coactivation. So I wouldn't necessarily expect EMST to improve things like voice or speech. Now, maybe it improves speech breathing and coordination. But I'd actually be more inclined to think that IMST has a better chance at improving our voice or speech outcomes because we now have greater access to air in our lungs. We can overcome that laryngeal airway resistance when we have more air in our lungs. And so I think it's just, again, it's a different way of thinking about it. You are going to set them up the same way. You can use a manometer if you have one in your clinic. Figure out what somebody's average maximum inspiratory pressure is or maximum expiratory pressure is, depending on the valve that you use on the manometer. And then set the IMST device to that. Generally, it's considered to be 75%, but there are studies where you'll see they train them a little bit lower, especially when you look at the IMST and ALS literature. It's lower. About 50% is probably a safe bet, sometimes 60% of that maximum inspiratory pressure. And again, and even with cardiac patients and hypertensive patients, I want to say that percentage is also lower. So again, it's figuring out what's the tool, what's the evidence say, and how do I take a patient who's never going to look like somebody in a research article? They never overlap enough. For us, we have to use our best clinical judgment. And so we ultimately are going to, again, we're going to do that. We're going to figure out what our best course of action is. And again, give it a shot. I think the research that I generally see is it's 6 to 8 weeks to see any kind of physiological benefit from exercise. Just like if you were going to the gym, you're not going to see, like I look and feel better after 2 weeks. It's going to take some time to figure out if you're getting this kind of long-term physiological benefit. So
I'm sorry, like you're putting out such good information. I just want to interrupt you for 1 second and go back.
Please interrupt me.
Go back to the manometer. People don't need a manometer necessarily because they can use the device and get at least an estimate, a little bit less precise, but get an estimate of what the maximum inspiratory pressure or maximum expiratory pressure is to be able to calculate this. So I just don't want anyone to get scared if they don't have access to a manometer.
No, of course. I mean, I think the manometer is like the most foolproof way. It is expensive, but most clinics have the resources to purchase them. They're, generally around $1,800 or something like that. But when the first clinic I worked in, we didn't have a manometer consistently. And you're exactly right. What we did was we basically would have the patient blow at a low threshold of the device. Let's say it was 20 centimeters of water. Centimeters of water is just a metric of pressure, just like millimeters of mercury or something else, another metric of pressure. But you'd blow into that low threshold and then gradually kind of quarter turn them up until they got to a point where they could no longer open the valve. And that's what's nice about these pressure threshold devices. Patients are very clear when they've done it correctly or not, because the valve either will open or won't. You've either generated enough pressure to open the valve or you haven't. So you get to a place where they can't, like they physiologically can't open the valve anymore. And then you say, okay, that's probably your 100% max. Let me ratchet it down to 75% of that. And so let's say for easy math, they can blow 100 centimeters of water. Well, all of a sudden, you are now setting that device to 75 centimeters of water where they can consistently open the valve, but where they're maybe not fatigued until that last five of the 25 reps that they're doing in a day. And again, that's the goal. The Olympics just happened, so it's fresh in my mind. The difference between a heavy lifter lifting their max weight, maybe they can do it 1 to 3 times, and then their muscles are just absolutely blown. We set it to 75% so that we can improve endurance as opposed to maximal strength output. We're working on coordination, even just the act of sometimes putting the device in the mouth, grabbing your cheeks, putting the nose clips on is an act of coordination, motor planning, and sequencing that patients have trouble with and need time to kind of get in the groove, find the habit.
Yeah, no, that sounds great. And one of the things with this, if we're talking about, you mentioned expiratory muscle strength training and inspiratory muscle strength training. So with either of these, see it as a strength-based training regimen. It doesn't necessarily, for swallowing, target the skill of it. So if you think of the idea of motor plans or motor patterns for swallowing and how things are going with that, you want to train skill, of course, as well. So this typically isn't something that's a standalone, but from the exercise physiology literature, we're broadening ourselves a bit and looking at stuff that's for strength training, for skeletal muscle, right? For weightlifting or for whatever. And the idea of lifting weights has been around for a long time. You're causing overload to the muscles so that they get stronger and they get better endurance. So we're taking that and thinking, okay, how can we use this in speech pathology? And well, look at this. We've got striated muscle in the diaphragm and these other places. So it makes a lot of sense. It's not something that's like necessarily revolutionary. It's kind of common sense based upon what we already know, but it's just a fantastic application. At least I believe it is. And so we've got just a little bit of time left, and we've talked a lot about the theoretical benefit to IMST. Do you think so far that the literature is supporting what we're hoping for?
Oh, that's a good question. So let me say this. I think the point you made about needing skill-based specificity is a really good one. I think I'm going to answer that question, but I'm first going to say
Yeah.
whether or not it's EMST and you're working on swallowing, so you pair EMST with a swallowing specific program, a skill-based swallowing specific exercise. That's always the goal. EMST is not a fix-all. It never has been. The same is going to be true with IMST. I do think that the literature is moving in a direction and significant enough over, some of these studies are 20 years old, 15, 10 years old, but over time, there is enough evidence, I think, to suggest that this has utility for us, that it's worthy of deeper investigation of people doing their own case studies. I don't see any evidence that it hurts our patients. I don't. And so with it, first do no harm.
Mm.
I feel like there's enough evidence to say, okay, number one, this is good. It may not be a perfect fit for everybody, but if you pair it with the specific task at hand. So again, like let's say I'm going to pair IMST with cough. They don't take a big enough breath in before a cough, so they don't have access to that large vital capacity. I better also be training completion of a cough. Completion of a voluntary cough. I should also be encouraging when they feel a tickle, upregulating their urge to cough.
Yep.
And what is a cough made of? Well, it's made up of 3 phases. You take a big breath in, you have a compression phase where the vocal folds close, and then you have this expiratory effort. That needs to be strong and robust and sequential often. So I think that point of, okay, so if I'm going to train cough with IMST, it needs to have a cough specific thing too. If I am going to target voice and voice outcomes, better have some stroboscopy to compare pre-post. I better have some voice specific exercises, maybe vocal function, maybe resonant voice, maybe forte, something like that. But I can't expect that these tools are one-stop shops for fixing our issues. But again, it's nice to have a strength training platform that can help support and facilitate the skill-based platform that we use. And I at this point, I feel confident with IMST in COPD, in the ventilator dependent, in our cardiac patients, in those with hypertension, in those with voice issues like paradoxical vocal fold dysfunction, or even those with presbyphonia. I think Two, there's only 2 or 3 studies on IMST with ALS, but it's interesting. It's interesting. And it's worth further discussion and investigation. I don't think it's going to hurt these patients, especially if it's done well at low intensity, low threshold for those kind of vulnerable patients, taking their entire medical history into account.
Yeah. One of the things, so you mentioned cough, the inspiratory phase, the compression phase, and the expiratory phase. I think one of the criticisms with this as it applies to dysphagia is you think when you first aspirate and you have that brainstem mediated reflexive cough, the inspiratory phase isn't there. You've got the compression phase and the expiratory phase. But when you're done with that, you better believe you're going to keep coughing, you inhale. and so that continues. So if you don't cough it initially, you're going to inhale. And so you need the inspiratory phase for that. And so, I mean, I think that's extremely valid. And so the idea of strength versus skill, I don't know the year of the article and I don't know the rest of the people on it, but years ago, Susan Langmore published something with some other individuals that looked at a review of swallowing exercises that we do. And some of the ones that seemed to have the best evidence were ones that were not swallowing specific. I don't want to knock down those things because I think it's extremely important. And a lot of it is just, we need more studies. We need more studies on patients with dysphagia versus just on healthy individuals. But this idea of transference, you're working the same muscles for a different task and hoping that there is transference into swallowing or cough or something like that. That's principle of sometimes I get neuroplasticity or exercise physiology. Boy, sometimes I get those conflated in my mind, especially when I'm on a podcast on the spot and have to think of it in 2 seconds. But it's based on science. But of course, then the skill-based training, you have the specificity of if we're going to treat swallowing, we need to incorporate swallowing. And so I think that is great too.
The same argument for general exercise, this idea of transference too. So it's like we encourage people to have a healthy diet and to stay hydrated and to exercise because all our body is an amazing machine, but it requires upkeep. It's like going to the mechanic and you want to treat it kindly and you want to do right by all the systems working together. And so I am somebody, even anecdotally, I can say as a clinician, I use those swallowing specific exercises all the time, and I find them to have robust effects. Now, if they're trained appropriately, part of that is clinician dependent too, because we're all different in how we cue. We're all different in the feedback we give, and what we think is good and what another clinician thinks is good might be different. So I think it's that balance of, am I pushing my patient hard enough? Not crippling their spirit and making them feel like they're not doing it well. I don't want to overload them and make therapy take hours in their day. But is it intense enough? Is it interesting enough? Do they care enough?
Right.
Do they understand what's happening to them enough to know why they're doing what they're doing? So our education of our patients is such a critical part of our therapy. So I think to your point, I'm as much as the evidence may be mixed, I think there's definitely utility for those swallowing specific, those voice specific, those cough specific trainings. And hey, maybe it's you need IMST and EMST in the same patient. That is okay. I mean, there are studies of them doing that in COPD or in multiple sclerosis and having benefits. Now, is that specific to the task, to what we're trying to train? That's yet to be seen. But if your best clinical judgment is showing you they have deficits on both sides. They have deficits on both sides. I really want to focus on X, Y, and Z. The best way I'm going to do that is with these 3 exercises, 2 of which are going to be a respiratory training tool. I don't know. It's going to be patient specific, but I want to encourage people to feel confident in these choices. And sometimes it just takes having a conversation like this to say, okay, why do we even use it? So that when you get to your patient, you can say, this is why we use it. And this is why I'm recommending it. And I have confidence that this is going to help you, not guaranteed, but I have confidence that through the literature that this is what it's showing.
Yeah. Well, I think it's a great way to maximize our time. We have a limited time with our patients. And so if we're doing everything that's skill-based or everything that's strength-based, I think theoretically we're going to hit a wall, or after I'm just throwing out a number, 2 or 3 skill-based exercises, like doing the first few sets might have a great, articulation is hard. Come on. Doing the first few sets, maybe you're getting proportionally higher benefit from that. But then if you start adding things, then you get a little bit less benefit. It's kind of like someone who works out a certain muscle group twice a week. On average, the day one and the day two, you get pretty good returns. But if you do 3, 4, 5 times a week, the change proportionally gets to be lower. But so for this, if you're then targeting it from a different angle, targeting strength of something related to the cough, because they aspirate, but they sense it, and you want to try to make the cough stronger. So theoretically, you're doing something that may help that, in addition to the skill-based training for swallowing. And so that's one of the major areas of utility I see. But there's so much more to talk about with this. Where can people get more information as we wrap up here?
So there are a ton of articles that we'll kind of work through and discuss at the upcoming conference, obviously. I think if you just look at respiratory muscle strength training, when you go to PubMed, there are a number of articles that will pop up, that are population specific. And oftentimes when it says respiratory muscle strength training, it's because it's incorporated the IMST, not the EMST. EMST tends to have its own search record. But if you look up respiratory muscle strength training or inspiratory muscle strength training, you'll have some success there. There's an article. There might be a couple reviews. I'm trying to think. There was a meta-analysis that I found recently, and I'm going to I'll have you put it in the show notes for sure. But there's one on voice from Desjardins and colleague in 2022 that I remember. There's Pinto et al. Did one in 2013 on ALS. There are a number of them. Oh, the meta-analysis was in hypertension, actually. And that actually, I think it might be a foreign study, but I'll definitely have to put that in the show notes for you. So it's there. The information is readily available. And I would just encourage you, there are always talks going on at ASHA about respiratory muscle strength training. Obviously, you'll see more on EMST than you will on IMST, but it's just worthy of having the conversation of thinking through the utility of it. And even think about all the anxiety we have, like when we can't breathe. So even if what we did for our patients was improve the work of breathing or their dyspnea, the perception of breathlessness, that might have enough utility for us to use it. Improve that coordination of breathing so speech comes more fluently and with less anxiety, and they finish sentences with more air in their lungs. Like I don't see negatives here. I think just doing your due diligence, talking to people, and listening to things like this give you all hints you need.
One of the questions that often comes up with inspiratory muscle strength training has to do, I think, with the scope of practice, like when we get kind of on the fringe of the scope of practice with breathing. So I'm just going to throw that out there. I'm not going to try to answer that question right now, but just to throw that out there is something to explore because we want to stay within our scope. But there is a lot that we can do with IMST that stays within our scope. So Dr. Brandimore will also be speaking at Rocky Mountain University's Hard to Swallow conference coming up. You can access that or information on that at peaks, peaks.rm.edu/course. That's peaks.rm.edu/course. It'll be at the top of the screen. If you're on a computer browser, it'll be top left. It's the Hard to Swallow, a Catalyst for Change in Dysphagia Management Conference. But of course, many of you will hear this episode after that, and that conference isn't recorded. So we will put some resources within the episode summary. And also Gap Education planning to offer some more things in the future. And so keep your eye out for that. And thank you all for listening. Alex, Dr. Brandimore, I appreciate you so much. And not just in this, Alex is an incredible person, everybody, in so many regards. Is there anything that you want to leave people with?
No, I appreciate you having me. It's always a pleasure. And I want us to critically think, to explore, to expand. And I feel like there is a lot of exciting stuff happening in our field. So just stay hungry, ask questions, reach out to any researcher or professor. They always want to talk to people if you guys have questions. So it's been lovely.
Thank you for joining us today to kick off Season 2. That was Dr. Alex Brandimore, an associate professor at the University of South Florida. I'm honored to say that Alex and I are former colleagues, and it's an absolute pleasure for me to have her on the show. As a reminder of our sponsor today, Aspire Respiratory Products, who makes pressure threshold devices for both inspiratory and expiratory muscle strength training. Find out more at EMST150.com. Don't forget to check out the episode description for resources, and you can catch Alex at the Hard to Swallow, a Catalyst for Change in Dysphagia Management Conference, which occurs September 20th and 21st of 2024. She'll be speaking on functionality of IMST for the medical SLP. Thanks again for hanging out, and we look forward to seeing you next time on Swallow the Gap.